quick review of how to diagnose gestational diabetes. So, diabetes developing in pregnancy. I find it incredibly confusing. There's multiple pathways to get to a diagnosis. And so we just laid it out here in this kind of flow diagram. So, first of all, gestational diabetes is when in pregnancy we're all a little bit diabetic because we try to make a sugar available to the baby. Sugar is a carbohydrate. Your body takes all carbohydrates and digests them down into simple sugars. And we use it to give ourselves energy. We put it in storage, but we also use it to grow our baby. For some women, they make too much sugar available to the baby. And how I describe it to women is like as if your baby was living in a candy store. The risk is that when the baby's born, it has trouble managing its own blood sugar. So when the baby has to go between feeds, the baby has trouble managing with those sort of normal dips and rises of blood sugar. And the baby can get very jittery or shaky, doesn't feel very well, just like us when we miss a meal. But also, the baby could also tip into convulsions. And any baby that has trouble getting started at the beginning when they're starting to breathe, they use up a lot of their sugar throughout the labor, birth, and in the initial period. And so they can burn through those sugars and not cope very well if they've always been used to a high sugar environment. So what we try to explain to women is that for women who have gestational diabetes, you really want to maintain a very steady, normal blood sugar range, no high peaks and no extreme lows, so that the baby's used to a normal blood sugar environment. The baby also doesn't grow big and fat. And when the baby's born, it can cope with that transition of going from constantly being fed through the cord to now learning how to breastfeed or learning how to feed, digest its own food, and they manage a lot better in the early postpartum period. A woman with risk factors for diabetes, we offer early testing. So testing in the first trimester. And those risk factors are family history of diabetes, first stage relative, so mother, father, sister, brother. If they had previous gestational diabetes, if they had a large baby over 4 kilos, if they're over 35 years old, if they have a BMI over 30, if they have polycystic ovary syndrome, they tend to be a bit insulin resistant, or corticosteroid therapy for any sort of medical treatment. So our first step when we first see a woman is we always draw a random glucose. And if it's less than 12 weeks, we can do an HbA1c. And if the random glucose is over 11 in that little snapshot that we caught her at in that moment, or if her HbA1c is over 6.5, then we automatically diagnose her as having gestational diabetes and we start to manage the case. We don't need to do any further testing to verify or rule out gestational diabetes. She just goes directly to a diagnosis of gestational diabetes. If those are normal, then we offer early screening. And so we can do a 50-gram oral glucose tolerance test where, or it's, I guess it's an oral challenge test if it's 50 grams, it's called. So where she drinks a sugary drink, an orange drink, and an hour later we draw her blood and we get a snapshot of what she did with the sugar. Did she take the sugar from the drink and store it, or did she leave it circulating at a high amount throughout her body and therefore exposing the baby to a high amount of sugar? So we do that in the first trimester if she's at risk, or we offer it routinely to all women in the second trimester. If the woman, we did it in the first trimester and it was normal, we did it because she had risk factors and it was normal, we can do it in the second trimester, so we repeat the test. If at 1 hour she's at 11.1, she goes directly to a diagnosis of gestational diabetes. We don't have to repeat or do any further testing. We start to manage the case. If she has a high level, so we caught her in the screening test of the 50 gram, then we go on to a 2 hour 75 gram And she's given more generous values. So a fasting of over 5.3. So in the 2 hour test, we have her come in fasting, so nothing before after midnight the night before. She comes in. We draw a capillary blood test because we want to make sure we're not giving her the sugary drink and her sugar is already really high. So we just need to know what she is in that moment. We ask her to drink the drink, and from the time that the drink touches her lips, 1 hour later, we draw her blood, and again at 2 hours. And we want to see that it's under 10.6 and under 9.0. If these values are elevated, she goes on directly to a diagnosis of gestational diabetes. We're done testing her for it, and now we're going to start to manage the case. In the event for some women who it's difficult to coordinate their care or she's late to care, we may go on to a 2 hour 75 gram in the second trimester. In this case, we're a bit more conservative of the cutoff values, and you'll see in the lab report that if she hasn't had a 50 gram, then to consider these numbers. So if her fasting was over 5.1, 1 hour is over 10, or 2 hours over 8.5, she's any one of those values are elevated. In any of these cases, if any one of those values are elevated, she goes on to a diagnosis of gestational diabetes. So now for these women, either who had a high random glucose, a high HbA1c, a high, really high 50 gram, or one elevated level in her 75 gram, she's now diagnosed as gestationally diabetic. So with gestational diabetes, the way we manage it here is we do diet counseling. And so I usually ask them, what did you eat last night for dinner? What did you eat for breakfast? And so what we're trying to get at is those high carbohydrate meals that have no protein, no fat, or crappy fats like trans fats. So what you want to see is like a bit of protein with every meal. So no, so quote unquote naked carbohydrates. So the carbohydrates should be eaten in the presence of protein and in the presence of fat. And that just kind of basically dilutes them so they don't surge into the bloodstream, causing these high peaks, which aren't good for the baby. Also discussing things like really easy stuff that she can change if she can is pop. So opting for no pop, no juice, instead just clear tea, coffee, water. If she's not lactose intolerant, something in the morning, a good breakfast is Greek yogurt. It's really high in protein, and just a few berries, a small handful of berries. Not low fat, but 2% yogurt. And so all we're trying to do is kind of get at where the carbs are coming from her. So if it's just sugar added to her diet, we can remove that. But there's also hidden things that people really like. Some people, for them, it's white rice. White potatoes really spikes their blood sugar, but sweet potatoes, baked sweet potatoes, do not. So it's what she's going to start doing is testing her blood sugar 4 times a day for 1 week. And so she does a fasting in the morning, then she'll eat her breakfast, and then 1 hour before her, 1 hour after her breakfast, 1 hour after her lunch, and 1 hour after her dinner. And in that week, we're going to get a handle on how she's managing her blood sugars with diet alone. Another trick she could do is walk for 15 minutes after meals, and then within that hour, her blood sugar is normalized. And if she sees she can do that, she's given a lot more opportunity to eat the things she likes. If she walks for 15 minutes, she's going to kind of normalize her blood sugar by the 1 hour mark. It's not cheating, it's just, helping her quickly normalize her blood sugar in that 1 hour period. You're also going to refer her to a nutritionist. So we have a nutritionist starting in Kuujjuaq as of October 10th, 2021. And so she could do a video conference with the nutritionist. A couple tricks that the nutritionists have suggested in the past is to normalize the fasting, is to eat a high protein with a bit of fiber just before bed. So a hard-boiled egg, something like a small bit of protein with some fiber like celery. That's going to help her normalize her fasting blood sugar. We notice that when we do a general internal medicine consult, they really focus on the fasting. So, if we want to avoid insulin supplementation required in the pregnancy and just have a diet controlled diabetes, really helping the woman and encouraging the woman to figure out how to normalize her blood sugar after meals, but especially fasting. And so it's going to be a bit of experiment at first, but if she can't control it with diet alone, then insulin will be recommended. The preferred insulin is injectable. There is also the option of oral if she's refusing insulin because of it's an injection. Also to know, please inform the midwives in Kuujjuaq because we'll need to make an arrangement for third trimester fetal surveillance. So those babies with gestational diabetes, especially poorly controlled gestational diabetes, there is a slightly higher risk of stillbirth. And we want to avoid that by doing a better fetal surveillance, more than just the regular routine belly check and asking about fetal movement. So let us know how we can make sure that we can make a plan for that. And then I guess finally, postpartum, these women are at higher risk of developing diabetes later in life, and so postpartum we offer a 6 week 75 gram test because maybe what happened is she always had diabetes before the pregnancy, but we didn't catch it. And it was only in the pregnancy we discovered that she has, in fact, type 2 diabetes. And so to please offer this 6 week test so that if she has type 2 diabetes, it could be well managed throughout, between pregnancies as well.